Hi everyone, this is Aki from Johns Hopkins Biostatistics. Today I'd like to tell you about a recent audit COVID-19 study I led with Mark Suchard and Dani Prieto-Alhambra. So here is a scientific question of interest. Here's a clinical question we were interested in. By now, it's widely recognized that many of the severe COVID symptoms are caused by our immune system overreacting to the infection. And somewhere along the chains of biological reactions that leads to this hyperinflammation is alpha-1 adrenergic receptor. So there has been a hypothesis that perhaps by prescribing a drug to block this signaling, we may be able to alleviate the symptoms of COVID-19. So in order to investigate this hypothesis, we decided to identify patients who are using alpha-1 blockers at the onset of COVID pandemics and compare their risks of severe COVID outcomes to those who are taking alternative medications. And since alpha-1 blocker is primarily used to treat patients with benign prostatic hyperplasia, we chose 5-ARI and PDE5 inhibitors as active comparators. And the diagram you see on this slide is the schematic of the prevalent user design we used in our study. And you can't run OHDSI study without a Greek acronym. So I gave this study an acronym APIS, who was a king of Argos. As many of you are well aware, defining what constitutes COVID positive diagnosis in this health data is not at all straightforward. But fortunately, in the OHDSI community, we have clinicians and informaticists who knows how to define these things in the right way. So in particular, I was able to take the phenotype definition the Charybdis team came up with and repurpose it for the AP study. And once we decide on the design, the study design and analysis plan, we generate our package and send it around to our data holder friends so that they can run the study in their local environments. And at OHDSI, we like to generate comprehensive evidence. So as is typical of OHDSI studies, we took all the possible combinations of the outcomes of interest, analysis plans, and available databases. So in total, we had 6 databases available to us with enough sample size. One from Spain, Catalonia, CDAP, and the other 5 from US. And our study included 3 million patients, 80% of which were on alpha-1 blocker and the rest on the active comparator. And of course, the OHDSI studies include many state-of-the-art statistical techniques that has been implemented in the Hades packages. So for example, in order to account for the difference in the baseline characteristics between the target and comparator group, we use propensity score method, which groups patients into strata within which their clinical characteristics are balanced. So here, if you look at the differences, standardized differences in baseline characteristics before and after stratification, you see that our propensity score method was able to balance the patient characteristics across the spectrum of baseline characteristics. Here comes the results. Does alpha-1 blocker has possibility to save the lives of COVID patients? Unfortunately, our study indicated no effect. So across 6 different databases, we consistently found that there's no difference in the risks of these severe COVID outcomes between Alpha-1 blocker users and the active comparator. So the observational data obviously has some issues, but this is nonetheless a strong evidence suggesting that perhaps we need to be looking elsewhere for potential COVID therapy. So yeah, that's the end of the talk. Thank you very much for your attention.